Yes, our final speaker is Dr. David Tomasi, who actually has made his doctorate, has defended his doctorate at Sofia University 7 years ago on medical philosophy, where the notion of consciousness and psychotherapy and self-awareness of the patient are involved. And afterwards, he has served two terms as a postdoctoral fellow at Sofia University, working in the field of philosophy of medicine, neuroscience, philosophy of psychotherapy, etc. Now he is quite established scholar in these fields. He is over, but I expect he to go further on in his academic. But I expect even more prominent schools to be eager to hire Dr. Tomasi very soon. Okay. Now I'm giving the floor to him. You're welcome, David.
Thank you. Thank you very much, Dr. Gungo. Can you all hear me well and see me well? All right. Sorry for the technical difficulties. All right. So, what did I want to say? How much time do I have so that I don't keep you too long here?
Well, it's up to Alexander.
Up to 30 minutes.
Okay. I'll be fast. All right. So, let me just do a quick introduction, and then I will ask to share my slides if possible. So there's one thing that I want to say right up front. The main focus of this presentation will be on ontology of psychological health, and to some minor extent of physical health. And so when we think about ontology, especially in my field, so medicine, psychology, neuroscience, we think about how we know what we know. So beside very important philosophical speculation, there is a direct application. So how do I know that a person is sick, for instance? How do I know that the label I attribute to this person is a correct one? And I was really pleased to listen to the previous three presentation, because spanning from Heidegger to narcissism, I feel this is the perfect segue, the perfect follow-up, because a lot of our mental issues have to do with how do we know that we are what we are, including from a perspective of what does it mean to be human. So thank you for the previous presentation on artificial intelligence as well. So one thing that we could say is in the application of this knowledge, having data from laboratory science is very useful. It's very useful for two main reasons. One, because you have to agree with it, as in is observable by everybody regardless of their philosophical background. Data is data, which of course does not mean that your interpretation is correct, but at least you have to agree on the scientific method you use, right? And the second benefit is that, at least in theory, it should remove bias. It should remove bias as in not forcing interpretations that are not predicated upon what you see, right? So this is the general outlook. Now, before we start with the first slide, I want to give an example. So I have a brain here in my hands, all right? You can see it here. And how do we know that this is not a real brain? Well, I can tell you this is plasticky. You can see it. It's just a model of a brain, okay? And you might say, well, you have to be able to take your statement apart for me to believe that is a brain made of plastic. And so I can literally do just that. I can just take the pieces of the brain apart and kind of prove my point here, if I can. All right, right here, all these little nice pieces. Okay? Now, this may be considered reductionist, materialist, okay? Because at the end of the day, this is still atomic matter, still based on physicality, okay? What it doesn't possess is the activation property. It doesn't do anything, it doesn't perceive anything, so we could agree that this is not a real brain, okay? Beside ontological consideration on the matter itself of plastic, this does not exist as a real brain does. It's a module, it's an image, okay? You could even make the claim, although it's a bit of a stretch, that it's a extreme application of the Begriff, the concept, okay? As in a Hegelian sense. It's application in matter. Okay, no problem. You don't really need to be a neuroscientist or a philosopher to know that this is not a real brain. What about this? What doesn't make it real? So you can see that this is a necktie, right? It's a cravatta. And yet, this cravatta is made of wood. It's a piece of wood. It's a piece of wood you can just move around, okay? So what is the level of this ontology here? What does a necktie do? Well, a necktie could do, a variety of things, keep it together, provide an aesthetic, pleasant, outcome. But in this situation, it doesn't matter if this item is not made of fabric. You could make the case that the ontology, the essence even of this, is consistent with any other type of a necktie. So in other words, the matter itself does not define the scope, meaning, and application. In other words, this item could exist as a real necktie. Okay? So this is just a premise. So if you don't mind starting with the first slide, so that I stop being only theoretical here. Can you all see this slide, the first slide? Okay, good. So this is just the intro, it's just the presentation, the title. And already here we might have a problem defining what we mean by processes and define what we mean by proprioception. I will explain this so we can move on to the next one, please, if possible. All right, perfect. Introduction, we can skip this brainy thing, the next one. Thank you. All right, good. Thank you very much. So, first thing first, how do we know what we know in terms of the data? So I will read from this slide. Let me just over here. All right, so from the perspective of the scientific method, we could certainly link health and well-being to those research variables which are more clearly definable as existing on a numerical scale via empirical, that is laboratory or hospital, detection, monitoring, and recording. For instance, we could think of the standard patient vitals. It has heartbeat, respiratory rate, body temperature, blood pressure, and oxygen saturation. So this is a start in terms of defining what we know by observation. Okay? Nothing surprising here. Okay. Next slide, please. All right, good. So minimum requirements to know what we know. Any subjective parameter would still have to be quantified. In other words, extracted and extrapolated from the single individual to be valid for the general population. And second, whichever experience and or process, mental process, psychological process, metaphysical process, it is certain that such process would also display a related physical manifestation. So let's take a break here. It's a big claim here, and you might already disagree with me. So first point, in order to verify our knowledge empirically, we have to translate the knowledge into numbers. That's really a big claim because you can make the case that it is not true, especially in philosophy, that you need to have a case control laboratory experiment to make something true. It's not necessary at all. In fact, you can get the wrong impression okay? Because, as I mentioned many times, numbers do not tell the truth, nor they lie. Numbers are just numbers. It's up to you to interpret them. But the second point is interesting. What I'm claiming here is that if we're talking about the ontology of psychological factors, at the very least, you have a higher degree of certainty if you find something in the body that proves the point. All right? Example, if I feel sick, okay, my self-perception of sickness is corroborated, is made stronger if I can see something occurring at the level of the digestive tract, for instance. Okay? I can still not say that I know what the other person is experiencing because I'm not them. And in that sense, we could think of the otherness, as in Levinas, Emmanuel Levinas, other. But at least I can relate to that because I can observe something physical, all right? So from the individual, from a subjective experience, to making the claim that is applicable elsewhere. Next slide, please. Physiology and psychology. Let me read from it. Which variables are we going to incorporate in our applied definition of well-being? Certainly, those labels which are intrinsically descriptive of problems involving, with a bit of neologist push, physicality and psychicality, which we could argue on the basis of laboratory evidence, are indicative of somatosensory or even psychosomatic activation. Take a step back here. We talk about psychosomatic medicine all the time, and some of the criticism might come from, I don't know, the use of the term in New Age circles, where everything is about your perception, and quote-unquote, biological medicine is not as important. And yet it's clear that, for instance, in the perception of pain, this perception occurs on a psychological level, whereby we mean an interpretation of pain by the subject feeling it. And this is interesting and useful because I cannot know how much pain you feel because I'm not in your body, and yet I do possess a body that is capable of pain. So, for instance, the fact that we are able to use our mirror neurons to feel another person's pain is yet another indication that we are more alike than sometimes we feel we can be. All right? A good example of this is what's happening in impaired processing of emotions. I did not include a slide here, so I'll be very quick. So I live in the U.S. and there's a certain area in the U.S., the outer coast, where it's very common for actors and presenters and musicians to get Botox implant to make their face more young and extended to look prettier. All right. And what happens, the research indicates, is that unfortunately botulinum makes your ability to produce facial expression more impaired, okay? So your smile doesn't become as natural anymore because your face is reconstructed, partially so. And you might say, well, you know, who cares, you know, beside, you know, your physical appearance? Well, the interesting thing is that if you are not able to replicate certain emotions, you will also be impaired in understanding those emotions in someone else's face. So there are kind of interesting things on both the good and bad side. So studies have shown that a person with extensive use of this, you know, fake Botox-based botulinum injection at first perceives less depressive traits. So the person might appear actually happier, all right? So there's less intensity. But it turns out to be that this is just masking intensity. The person is not able to recognize social cues from other people suffering or being happy. So they're kind of prisoner on a superficial level. And this is fascinating to me because it's like we know about narcissism, and this is exactly when narcissism occurs on a physical level. Fascinating. All right, next slide. Great. Sample studies. So I don't want to use too much of your time, and I just decided to include 4 research studies that my team and I conducted in the last 5 years, I think, that take on different angles, but they come down to very similar conclusions. The first one is olfactory virtual reality for well-being and reduction of stress, anxiety, and pain. The second one, positive patient response to a structured exercise program delivered in inpatient psychiatry. The third, human gastrointestinal microbiota and neural activities, effects of probiotics on mental and gastrointestinal health. And the last one, emotional and cognitive responses to academic performance and great anxiety. So why did I include these studies? Now, as an example, really, but going back to the title, this mini presentation is an examination of neural proprioceptive factors. So things that happen on the brain that determine how we feel in relation to pathophysiology and ontology of psychophysical health. So from what we perceive with our body to what our body does to what our judgment is. So in these 4 studies, we take 4 directions. In the first one, very similar to Mao's presentation, we talked about something that is not real, is artificially constructed by a computer. In the second case, we could say this is the application of embodied cognition via exercise. In the third, it's also physical, but not at the same level of awareness. In other words, you're not aware of what's going on in your gastrointestinal tract to a very big extent, or at least not as much as what happens in your muscles. Okay. This is not entirely true because we do have neurotransmitters like serotonin in our gastrointestinal tract, but overall. And the fourth one, in the way we label ourselves, self-identification. Okay, so these are the 4 directions. Next slide, please. All right. So, physical activity, sensory motor activation, physiological response, and self-perception, part 1. I will not read you the specific values of the study, but what we find out is really nothing new. It's something that I think everybody knows instinctually. What we find out is that exercise helps, physical activity helps, and helps on a variety of areas, from reduction of stress, anxiety, emotional and physical pain, all the way to an improvement of mood. Okay. So this is pretty much straightforward, no surprising factors here, but 2 important outcomes. One is that if your body feels better, your body will secrete those very chemicals that will help your brain think that you're feeling better, right? So it's already a good place to start because you will be able to sorry, I'm just looking at the chat here to make sure I'm not mixing anything. You are able to tell yourself that this is worthy. Okay, it's your body telling you. The different thing is that it's not you're not believing the doctor, the therapist. Do this and you'll feel better. It is your body that tells you that. Okay, so even from the perspective of extreme self-centered narcissism, this is nurturing. Why is this important? Because from an ontological standpoint, from the description of what makes something, a narcissistic, self-centered person is really the same as a very altruistic person. All right? What happens is that they're both obsessed with the judgment of others. The narcissist is entrapped, engulfed by it, because their benefit from pleasing others if they are under the spotlight. But if you remove them from the stage, they are miserable. And the altruistic person, when this altruism doesn't stem from a solid, I don't know, metaphysical essence, but it's simply trying to do the best you can to help others. If you don't have self-analysis, what happens is that you keep helping others simply because you cannot deal with them saying no to you. You cannot deal with disappointing others. So you're still obsessed by others. If you do physical exercise, everything is removed. It's not about your self-perception, it's the direct connection with your body. So it's a practical application of embodied cognition. Okay? It's not versus, it's not philosophy versus empirical science. It's not psychoanalysis versus physical exercise. It's a combination of these two from a different angle. Next slide, please. All right, so part 2. Just the last part here. I'll read the last paragraph. This is exemplified in the affirmative answer, so yes, to after attending this group, do you think you will exercise more? With 97.6 for the first study group and the totality of patients on the second subject population examined, 100%. So a quick thing about here. Those studies have been performed in an inpatient psychiatric unit where we have multiple diagnostic presentation. So we have something from mood and personality disorder, bipolar, borderline, narcissistic traits, hedonistic traits, all the way to neurological disorders, schizophrenia, schizoaffective disorder, psychosis, dementia, Alzheimer, a bit of everything. And the fact that the results are consistent means two things. The first one, it's kind of, easy to understand, that exercise works across the spectrum. Okay? Not surprisingly so, because even if your mind is impaired, your body may still function. But the second thing is much more interesting. Because you're removing words, you're removing conceptualization, you're removing theory and psychotherapy, even the people that don't have a strong cognitive capacity because they're, suffering from dementia or Alzheimer, still feel the benefit. So it's the body speaking for them rather than their higher cortical function. And that makes them more prone to come back to the exercise group or really to any other group. So even to do more psychotherapy because they start understanding what you're saying from a body perspective, from a body cognition perspective. You could say it's similar to emotional intelligence. So it's quite fascinating. Next slide, please. All right, so this is OVR, olfactory virtual reality. I will not spend too much time on it. And I have a few videos that explain this in detail, but my team collaborated with a local company that's called olfactory virtual reality, OVR. And what they created is this device that combines usual virtual reality goggles, and it creates a virtual reality environment, with olfactory bulb stimulation to smell while you're interacting. So long story short, the people that we examined were able to walk around the woods, smell, the leaves, feel the air, interacting with stones, moving objects like a table. And just because we are in America, roast marshmallows. That's what we did. So today is Thanksgiving. So I guess that's part of the research. So anyway, they were able to interact visually while perceiving that with their noses. Okay? Again, the research was very positive. And to be fair, for this research, we only work with subjects from the mood and personality disorder, not schizophrenia, not psychosis, because that adds a risk. And the risk is to dissociate or having even more triggering experiences. But positive responses in the same areas as before: pain, stress, anxiety, overall mood. And there are two main reasons why we did this. One is because if you are physically sick, you cannot exercise. So at the very least, you can make your brain pretend that you're exercising by interacting in a virtual reality sense. So this device can be used even if you're just sitting down, you're in a wheelchair, or even in your bed. You don't have to have the capacity to interact. And two, because the olfactory bulb, the sense of olfaction, the smell, it's really the only sense in our body that bypasses, or almost completely bypasses the thalamus, and so you have this direct understanding of what's going on, okay? So this is another, if not proof, but indication that our bodies can have a wisdom that sometimes our mind alone, our psychological factors alone, might not be able to grasp. All right, next slide, please. All right, this is just overall results here, and I'll let you read the numbers. Now, of course, in these studies, while we did monitor patient vitals, those 5 that I mentioned at the beginning, because in every hospital you should do that on a regular basis. So we knew that the patients were doing well in terms of oxygenation, heart rate, blood pressure, etc. We also needed some qualitative measures because we had to ask them whether the thing we do worked. So this is doing the opposite from an ontological perspective. So at the beginning of this conversation, I said, it's useful to find something in the body to make sure that your claims are correct. Now we're doing the opposite. In order to make sure that what your body is telling you is the truth, that I should be able to ask you, and you should feel it in your own words, the fact that you're feeling better, okay? Because otherwise what will happen is that I come to you, let's say you might have had a surgical procedures, and you're in excruciating pain, okay, after the surgery, and here I'm telling you, well, I give you this medication, you should not feel pain. And you might say, well, but I do feel pain. No, you're wrong, because I can see here that based on your neurotransmitter, you should not feel the pain. But the point is that you might still feel it despite of what I'm saying is the truth. So the fact that we can ask them and we find this correlation between, on this level here, the physical patient vitals, and on this level here, your perception, if they're aligned, we could make the case that we still don't have 100% certainty that this is the ontological truth, but we're getting very, very close. All right, next slide, please. All right, anxiety and performance. This is nothing to do with a patient population. This was a study done on students, in college and university students, and we simply wanted to monitor how stressed they are about their grades, which is the opposite side of narcissism. In the US, there is a education system that is kind of to some extent similar to the European ones, but also very different. And so the level of filtering, quote unquote, good performing students from more poorly performing students doesn't happen as soon as it happens elsewhere. You usually wait until you're in college or even, at the later stage of university. And so a lot of students might perceive this as a shock. They perform very well in, elementary, middle school, and high school. And then when they need to submit their, GDA scores for university, they realize that they're not as knowledgeable as they thought they would be. And so there are good and bad things about that. The good things in the US is that from an inclusive standpoint, there is no child left behind. So it's very nurturing, it's not judgmental. So you can learn at your own pace in elementary school. But the downside of that is that only later you'll find out that you had to study a little more to perform well on a test. And so this anxiety comes to you all at once when you're, let's say, 19 or 20, okay? So can you still hear me, by the way? Okay, because there's no feedback volume anymore, so that's good. So very small study, this one only 75 participants, But the general idea is that everybody was very much anxious. And let's just take a look at the last paragraph here as well. Among the most interesting data observed, out of 75 respondents, 65 said that they procrastinate in academic setting, and only 17 out of the 35 report a GPA below a 3.5. Okay, so if you're not familiar with a GPA, it's just the average grade required to continue graduate studies in the US. The top will be 4.0 or 4.5, depending which metric system you use, measuring system you use. So what happens here is that students are overall still doing well. 3.5 is not too far away from 4, and yet they do procrastinate, okay? So there is some sort of psychological problem here. The anxiety takes over their performance capacity because they put on hold what they think they will feel, okay? They're kind of scared of that, all right? Which is, of course, it's kind of a catch-22 because it makes them eventually less prone to perform well on those very studies, okay? So again, nothing that you probably don't know that, if you study, you might have some anxiety. But the fact that you might not be aware of the fact that these two can be a predictive factor on your performance. All right, next slide, please. I'm not sure if we lost it. You lost connection? I think so.
We are long day, don't worry.
Okay,
You can continue for us.
Yeah, sure. This is the slide, just FYI. Okay. So I'll be fast because it's already 9:40. Well, 9:40. What is it later? 5:40 in Moscow, I believe. Anyway, I'll be super fast. So in the next few slides, I discuss the main topic, ontology, and I say a few things. First of all, that we use different terms to define how we are sick: illness, disease, disorder, syndrome, trait, mutation, mistake, and variable. All right. And so this is one element. And then that we use different labeling lists. So we have the ICD in the world, the International Classification of Diseases, which is the one that's published by the WHO, the World Health Organization, that talks about physical problems and psychological problems, psychiatric problems. But in the US, we tend to use the DSM, the Diagnostic and Statistical Manual, all right? Now, keep in mind that the DSM is exactly what it does. It's just a diagnostic and statistical manual. It doesn't talk about ontology whatsoever. It doesn't talk about etiology whatsoever, okay? And again, this is not a question of politics, okay? My argument is not the ICD is better than DSM, or the American Psychiatric Association that published the DSM doesn't know what they're talking about. What I'm making here as an argument is that the way labels are constructed is in itself a product of the social context, okay? But there are two extreme perspectives here. One extreme will be that, well, if it's predicated on the social context, really, who cares? We talk about real science here. Your interpretation doesn't matter. Let's focus on neurotransmitters, okay? Oh, thank you for this slide. I think we can move on to the next one. Thank you very much. And by the way, this is just an image of dopaminergic factors. And so far, I talk about serotonin, which is one of the chemicals that is responsible for mood and well-being in a psychological sense. But dopamine also gives you the energy. So in the context of exercise, this is what you perceive to be true. So one extreme of this argument is to say that your interpretation doesn't matter, social factors do not matter, social context doesn't matter. So anybody who would be really anybody within the continental philosophy area, all the way from the Frankfurt School to postmodernism, including neo-Marxism, and even people like Lev Vygotsky, for instance, in psychology, social context, social constructivism, all this down the drain because it's only biology that matters. That will be an extreme view, okay? It's an extreme view because it doesn't say anything. Again, just because something occurs in your body, you still need to have interpretation, right? Just because your body feels sick, you might not feel sick in the same way. Classical example that you don't need to be a neuroscientist. You can have a high temperature, a big fever, but if you are in love, really, you don't feel as sick. If you experience that in your life, you know that to be the case. Okay? You can put your physical pain on hold. But then there's the opposite extreme, where no biological factors are relevant, only your own interpretation is. Okay? And there's another risk where everything is up for debate. Now, I love philosophy and I love true, solid philosophical debate. But what I observe is that very often this is used as an excuse to make everything up for argumentation. So it is true, as in the previous presentation by Alexandra, I believe, that there is an increase in narcissism in our modern societies, and I would say even more so in a Western aligned society. But the same can be said about a variety of things. There's an increase in ADHD, attention deficit hyperactivity disorder. There's an increase in depression. There is an increase in DSDs, disorder of sexual development, especially when those disorders are predicated upon self-perceptual mechanisms, okay, identification mechanisms. So there are two options here. Either the world is getting sicker and sicker, and from a metaphysical standpoint, perhaps you could make the case, okay? And yet you have to provide some solid data. I just want to mention here two opposite works to make the point. One will be the work by David Berlinski in France, who argues that society always gets sicker and sicker in cycles, kind of an eternal return type of thing, a Nietzsche kind of eternal return. So there's nothing new about our modern society. And then the opposite claim is made by people like Steven Pinker, who thinks that we are indeed getting better and better, and our society is becoming healthier and less violent over time. So two opposite perspectives here, okay? Now, I want to show you the last slide and then I conclude, if you don't mind. The next one is the very last one. It's this one here, just in case. Okay. All right. And it's the slide where hopefully everything comes together. It's just an analysis of mirror image and mirror neurons. All right. So I will just read from it and then we can conclude. And if you have some question, feel free to ask. The most current scientific discoveries in the application of multiple somatosensory and motor stimulation, so right here, in combination with virtual reality or brain-computer interface, is essentially the same. Even as, other than me, this specular, this doppelganger, this mirror image, as our poetic self, our creating self in the world, is the one we inhabit and we live, okay? So by inhabit and we live, I mean this in an accusative sense, not locative. In other words, we exist in the world not as passive observers, although we can take that role, especially if you do observational science, but we also act on the world. And so in this sense, it's not too different from what the previous presentation said about the signage being the Sein and Zeit in Heidegger. So how can we make the claim that, going back to the beginning of this presentation, there is a link between neural proprioceptive factors and the pathophysiology and ontology of psychophysical health? In two main ways. One, that proprioception, it's not necessarily perception. In other words, proprioception is how our body feels about itself, okay? And so you have this neural mechanism that shows that, okay? But with that, you also have perception because you exist in your body, okay? And this informs the way the body processes that, pathophysiology, and the way you can claim that you are sick or healthy on a spectrum. To conclude, it might feel very harsh for me to tell a person who is, let's say, suicidal, I know you better than you know yourself, because it feels judgmental. How can you possibly claim that you know me? You don't know what I went through. You don't know what trauma I experienced. And yet, it might be the right thing to do, right in terms of clinically, scientifically, and ethically, because we have the same neural mechanisms, and it could make the claim that not just irrespective of what you went through, but very often because of the suffering you went through, your life has even more meaning. So the fact that you cannot see that, that is the sickness. Your inability to see the beauty, the truth inside of yourself. Thank you.
Thank you very much, David, for your really deep and informative presentation. Now I'm giving floor to the participants for questions. I see that Natalia might have a question.
Okay.
David's presentation was amazing as always. I don't have a question, but I am looking forward to reading your paper.
Thank you very much. Thank you. Благодаря, Natalia. Thank you. Thank you.
So do I, David. I also will be very interested in reading your paper. But how about Sean? Sean, if you have any questions, if you are still okay.
Oh yes, I'm still here. I just turned off my cell phone, but I'm still here. I was curious. How widespread is the ideas of Heidegger in the psychology or psychiatric profession? Is it something that is overlooked nowadays, or is it something that is regaining currency?
Heidegger is a fascist. By this point, everybody's a fascist in the US. It's not really well perceived. Jokes aside, let me put it this way. The United States, to a big extent, is still very much aligned to the Anglo-Saxon philosophical view, a very analytic philosophical perspective. So in this sense, you could say that they're opposite, right? So they're analytic as opposite to continental philosophy. And yet, in my estimation, this is just my opinion, they're also losing ground in analytic philosophy, because a lot of their claims, especially in psychiatry and in psychology, in my view, has been hijacked by pseudo-philosophical, pseudo-sociological claims. I can just think of, sorry for being judgmental, but the level of depth between a Heidegger or even Husserl, or even Derrida, even Camus and Sartre, all this in comparison to Butler. I mean, we're not talking about the same philosophical depth. And so my estimation is that Heidegger is misunderstood in two ways. One, and this is more on the, narcissistic perspective. In the US, Heidegger is perceived as so complicated to read that because it's complicated, it means that he's probably very smart. It's a claim that very often it's made in, contemporary art, okay? So sometimes you see some conceptual installation where the installation doesn't make sense to you, and a person might tell you, well, it's because you don't understand it. It's too deep for you to understand. And you say, no, the person is just not able to paint something properly, okay? So there's one level, okay? They're confusing depth with complication. And to be fair, yes, Heidegger is complicated. Even if you read it in German, sometimes you might have could you just say that in 2 sentences rather than 60 pages? Sure, I'll give that to you. But the other claim is that, well, who cares about his philosophy? I'm not going to read any books, but he was affiliated with the Nazi, and therefore everything he could possibly write is Nazism, okay? Never mind, Hannah Arendt, never mind, it's just a label. And so I feel he's not well known, just to put it up front. In psychiatry, Heidegger is not well known.
Very interesting. Thank you very much for the presentation.
Okay. Thank you, David. Thank you for the question. I'd like to ask a question about a term which is not very scientific and not very philosophical, but I would like to hear your opinion, David. The term is psychic vampire. And by psychic vampire, I mean people who are over extrovert and who aggressively approach the others and not necessarily with egotistic intentions, but even with altruistic intentions. And more probably, I would think the term egotism and altruism is inappropriate for them because they're just absent-minded, but very aggressive. So my first question is, do you think this popular understanding could be translated into a scientific or into a philosophical term? First question. And my second question, can you claim that contemporary media, to a certain extent or very much so, act as psychic vampires? Thank you.
Wow. Thank you. What an interesting question. I'll do my best to be brief and rational as I can. First level of my answer, I'm not sure, simply because I cannot think of an experiment that could prove that, empirically speaking. But I think I have a hint, a quite solid hint. So in this sense, you could interpret psychic vampire as a term on two levels. Psychologically personal, as you just expressed. A person that could be viewed as, passive-aggressive even, okay? Now, passive-aggressive is not really a term that we use in psychology anymore. It's kind of a Freudian term that doesn't find a lot of evidence anymore. But we could say a person within cluster B personality trait. Okay, so a person who has very highs and lows emotional display. For instance, borderline, a person is so attached to you that has this extensive need to figuratively suck your energy out to attract you to themselves because they want to swallow you. So in that sense, it's a vampire, okay? And it's a misplaced function of mirror neurons, really. They want to suck you in because their self-identity does not exist except in relation to you, okay? So I'm nobody except from your boyfriend, your girlfriend, your student, your professor. I'm only existing in relation to you, personally speaking. The second level of psychic vampirism, I guess, could be societal one. It's quite interesting how that happens in terms of groupthink. Now, the research is pretty clear that groupthink, it's not as useful or even truth-producing as we thought in the past. By groupthink, I mean, in the US, very often, every time you go for a training, if you start working in a university, in a hospital, they make you sit down in a group of people and then ask you to come up with a solution to a problem, okay? Think about, inequality in the world. You sit down, 20 people, you come up with a solution. This feels very good in group, but it turns out to be that the solution itself, it's less profound as if you work independently and then you bring all your conclusion together. Similar as the peer-reviewed process, okay? You write a paper on your own and then you bring the paper to a committee and the committee reviews it independently of you, okay? Why is this the case? Well, you can make the case that people might want to be nice, so they don't want to tell you in your face that your argument is bad. So they kind of politely, step back. Or it might just be the fact that people enjoy talking, but they're not coming with a conclusion. So in this sense, you have a circular vampirism. Everybody takes out from the other person, not the good, but the bad, okay? This could be also applicable to societal norm, for instance, when we talk about social policies and spread panic in society, okay? When a single person feeling of, uneasiness is then pushed onto society so that everybody should feel that same pain. I want to give an example of this, okay? An example that I use from time to time. Think about words that are perceived as offensive. Okay? Now, in the United States, because of the history of slavery, rightfully so, we should be careful not to use the quote-unquote N word. And that is the ethical thing to do because, the history of the United States is very bloody in regard to the treatment of African Americans. Sure. What's the issue? Applying that elsewhere outside of the United States to claim that any word remotely connected to the same etymology is in itself racist, fascist, or offensive. Now, you're going to toss into the trash all the Romance languages, I would say minor Romanian maybe, but, from Niger, Negro, Nero, that's the term for blackness, okay? And on top of that, another argument I can make is that even if you go to the etymology of blackness, the term black in Germanic languages is connected to bleach, which means to burn out of whiteness, okay? Think about the fact that bleach can burn your skin. So the burn, it's darker, but the bleach it's actually wider, more broad. So this is just an example of psychic vampirism. A person might feel something as threatening to them and forces everybody else to recognize the danger instead of working on themselves and see why they feel a certain way. Did I answer?
Yes, thank you very much, David. Very enlightening answer. It stimulates some other thoughts in me and I hope in other participants. Now, I would like to thank everybody for her or his participation. And I have just received a message on WhatsApp that on the conference site, there was a fire alarm. That's why they disconnected.
Oh, wow.
And message said that they are all right, but there is this alarm and they disconnected and they excused themselves for this. So we are finishing the conference by ourselves. Hopefully everything is all right at the university, and I look forward to our next meetings and our next exchanges. All the best to everybody.
Thank
you
you
very much, and happy Thanksgiving, David.
Thank you.